All right. Hi, everybody. Welcome back to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Kerry Reller, and today we have a very special guest, Dr. Emma Westerman. Welcome to the podcast.
Thank you so much, Dr. Reller.
Yeah, I'm super excited to have you on today. Plus, I feel like I've gotten to know you over the time bothering you with text messages and things. So I'm excited to hear all about you and your expertise today and what you've been doing lately. So why don't you tell us a little bit about who you are and what you do, and then we'll obviously go into more detail later.
Well, I am a clinical immunologist. I have my own practice in Tampa. It's called HealthSpan Immunology that I actually just opened in November 2024.
It's super exciting, definitely different from what you were doing previously. So you trained in Tampa area as well, right?
Yes, I
Yeah.
did residency and fellowship in allergy immunology at the University of South Florida. And
Mhm.
then I worked at USF for a while, and then I decided to open my own practice.
Awesome. Okay. And you are expert in immunodeficiency. So I wanted to get, all the knowledge from you today about that. So can you tell us what is immunodeficiency?
Sure. So the immune system, as you know, because you do quite a bit of allergy and immunology as well, is very beautiful and complex and involves a lot of different cell types. So immune deficiency can result from problems with really any of those cell types. I like to think of it that way rather than putting fancy labels on it like innate problems and humoral immune problems. Immune deficiency can result from issues with the B cells most commonly. Those are the types of cells that primarily target bacterial infections. And then there's also T cells that primarily target viral and fungal infections. There's also neutrophils, which are part of your innate immune system. Those are kind of like your first line of defense. So
Mhm.
a person with immune deficiency can have deficits in the number or function of any of those types of cells, and there are many more beyond that I won't go into. But the common types of immune deficiency that I see include common variable immune deficiency, which is a problem with antibody production. It's actually an umbrella term that encompasses a lot of different genetic disorders. So I like to dig a little bit further and do genetic testing to see if we can
Mhm.
find out exactly what's going on.
For our listeners, can you explain like what an antibody is? Why is that important?
Sure. So an antibody is produced by a B cell and it targets whatever infection is going on in your body at that moment. But your body is also constantly producing kind of a random assortment of antibodies, some of which actually target self antigens. So you may produce antibodies that accidentally, you could say, target your thyroid, and then you could develop autoimmunity,
Mhm.
thyroid specific autoimmunity. Or you could develop antibodies that target your platelets, and then you would develop something called ITP or immune thrombocytopenia. And that's actually very common in patients with immune deficiency because the problems that lead to poor antibody production and immune deficiency also lead to autoimmunity.
Yeah, like we were talking earlier, we get lots of confusion around the whole immunodeficiency versus autoimmunity. So I think you kind of really helped to clear it up a little bit. But immune system is such a complicated thing. And I think it was one of the harder things to learn in medical school. And I think most people would agree. You got all these different cell types. You have to know what they do and how they interact with each other. And then obviously what we're focusing today is also like how they're, fighting infection and disease. And so, like you just said, they can even somewhat cause this infection and disease too, right? So you mentioned the
Exactly.
CVID or common variable immunodeficiency. What you were going to tell us some more about that and other types of immunodeficiency that you see in your practice.
Yeah. So just to tie that autoimmunity issue with the bow, there are many patients that will present first with autoimmunity and they'll be seen by rheumatology or hematology because they have a problem like immune thrombocytopenia.
Mhm.
And they'll kind of linger in those clinics for a while, and not until years later are they discovered to actually have an underlying immune deficiency. So if autoimmunity is discovered, especially in child, teen, young adults, I suggest that people check at least immune globulins and lymphocyte subsets,
Hmm.
which looks at, how many white blood cells of various types does the person have, absolute lymphocytes, NK cells, et cetera, just as a screen. And if anything is abnormal on either of those, the patient should be referred to immunology.
Yeah, that's a really good point that I think, like you were saying, like some people can get missed or get delayed diagnosis. Like this is something that I think people spend a long time suffering and have no idea. But then obviously there's cases where it's picked up a little bit earlier too in kids, I think, because something is definitely wrong. Yeah. So go ahead. You were still saying, I hope I didn't cut you off, but
No, no, not at all. Exactly. And they may have had a relatively mild infection history in childhood prior to developing autoimmunity. Maybe they were an ENT frequent flyer, maybe got ear tubes or adenoids out, but they don't
Mhm.
have to have had, recurrent pneumonia requiring hospitalization or what have you to have pretty serious underlying immune deficiency. It's not uncommon for it to be picked up in teen years and young adulthood.
Mhm.
And that's what I love about this field is I get to help people who have been kind of bouncing around from doctor to doctor. They know something is wrong and they just don't know what. And we can do that really in-depth testing and genetic testing to help them. And it's important to catch them as early as possible because some of them will require pretty intensive therapy and may even require bone marrow transplant in some cases. And you really don't want to miss that window.
Mhm.
Sorry, you had asked, I digress, you had asked about what types of immune deficiency I see. And I talked about common variable immune deficiency,
Mhm.
which is an umbrella term. There's also specific antibody deficiency, which is similar, more mild in that they make enough antibodies, but those antibodies aren't very good. They don't function all that well to fight
Mhm.
off infections. So we look for that. And then also there are chromosomal abnormalities like partial DiGeorge syndrome and Down syndrome that can lead to immune problems. There are certain immune deficiencies that involve not only the B cells, but also the T cells.
Mhm.
Some of the more common ones that have historically fallen under the CVID umbrella are NF-kappa B1 deficiency and CTLA4 haploinsufficiency. So when we do the genetic testing, those are some of the ones that we might pick up.
Mhm. Mhm. So before all of the testing and stuff happens, there have to be some sort of early signs and symptoms that someone might suspect that you have an immunodeficiency. Can you kind of go over that a little bit for us so we could learn how to recognize it?
Sure. So anyone who has had an increased number of infections relative to their peers should be kind of on the radar. And like I said earlier, it doesn't have to be extremely severe, life-threatening infections, just an increased number. Maybe they had 6 sinus infections requiring antibiotics, whereas their friends only had 1 or 2 per year. And so increased number of infections, sometimes severe atopy, like more really severe eczema can be an indicator of an underlying immune deficiency. And then autoimmunity, as I mentioned, especially in young people. But in older adults, in their 50s, 60s, it's not uncommon for them to have lived a relatively normal life. And then all of a sudden they're getting more infections and they can be diagnosed with CVID at that point
Mhm.
and require support with immune globulins and other treatments, which we'll talk about later.
Mhm.
I've even diagnosed people in their 70s with monogenic disorders.
Wow. Where would type 1 diabetes fall in this class? Do you think, like, do they also present with some immunodeficiency problems? They already have deficient, problems with that in general, but because it's an autoimmune disease, right?
Yeah. So there are certain immune deficiencies that are known to, you know, th- they're characterized by autoantibodies against, the pancreatic cells that lead to diabetes. There are a few monogenic disorders like that. But in general, because type 1 diabetes is relatively common, I wouldn't say that that alone would lead me to investigate for immune deficiency.
Okay. Yeah. I mean, they're already, at like increased risks of infection and poor wound handling and all those things. It's hard to imagine that they could have something else on top of it. As I feel like if that was even a case, it would be very difficult to distinguish.
But certainly it wouldn't hurt to
Yeah.
just check
Yeah.
immunoglobulins and lymphocyte subsets.
So
Yeah.
you kind of touched it already, but any different signs of warning versus children and adults or?
So I think we pretty much covered that. Adults who develop multi-system autoimmunity, that would be another clue. They've got colitis and thyroid autoimmunity,
Okay.
and ITP, say, we want to check. And also adults who develop leukemia or lymphoma in like young adult.
Mm-hmm. Mm-hmm. Yeah, I figured you had kind of said all the different warning signs, like you mentioned frequent ENT visits, frequent sinus infections in need of antibiotics and things like that would be one of the triggers for that. Obviously, pneumonia, hospitalization, sepsis, things like that would definitely be higher on your, I guess, higher for you want to test them. Okay.
Really.
So we kind of already did a little bit of this, but how is it like diagnosed? There's a bunch of different blood tests, and I know they're complicated, but can you simplify it a little bit?
Yeah, so we look at the different branches of the immune system through kind of a standardized protocol, shooting for the more common immune deficiencies first, looking at immune globulins and lymphocyte subsets as a screen. I
Mhm.
also typically add on titers to different vaccines that most people will have had in childhood. Like most kids will these days will have had Prevnar and hip vaccines and so forth. So we check titers to those, also diphtheria and tetanus, and look for a pattern if a person has low titers to those vaccines, then we can try revaccinating and see how they respond. If they don't respond, then that indicates a functional problem with their B cells. And then, T cell disorders are less common and the testing is more expensive. So I reserve that for patients with, clear history of viral and fungal infections that are recurrent. We can do that T cell specialized testing or
Mhm.
NK cell functional testing. Some of those labs are send outs to specialized labs like Cincinnati Children's. So I would only do those in patients whose history kind of matches. There's also, tests to look at neutrophil function and so forth. There's many, many
Mhm.
tests. And then genetic testing,
Mhm.
we can currently look at over 400 genetic immune deficiencies with one cheek swab or one blood draw.
Mhm. That's pretty amazing, the changes that have happened, and I think in this field over time, right? With all the
Yes.
testing available.
In 2018, it was like 35 genes. It's amazing.
Yeah, it's crazy. I mean, I feel like I always am, telling patients, you're going to get a lot of blood drawn, but, I think we'll, get some answers and then be able to retest if needed and things like that. But like you're saying, some of them are more complicated and send outs and more expensive that we kind of reserve for, different presentations and things like that. Right. Good. So I guess once you have a positive screening test or test, how do you, or once they're diagnosed, what is available in treatment for these conditions?
Well, for B cell conditions,
Hmm.
we have many different immune globulin products, which are basically pooled antibodies from 10,000 healthy college students that replace the missing or dysfunctional antibodies that the patient, lacks. And so if we give them those replacement antibodies, then they're more able to fight off infections when they encounter them. And that can be done through a monthly IV infusion, called
Hmm.
IVIG, or a weekly or biweekly subcutaneous infusion, which patients can actually do at home after being trained by a nurse. And then for certain patients, they also require prophylactic antibiotics on an ongoing basis. And then, we talked about the autoimmune issue. For patients with autoimmunity and immune dysregulation, it's kind of counterintuitive because their immune system is quote unquote low, but we actually have to suppress their dysfunctional immune cells with immune suppressants, including, sirolimus, Cellcept, sometimes rituximab,
Yeah.
that can help reduce the autoimmunity.
Even like we were talking about progress in this field too, like it used to only be IVIG, and now they have all these, subcutaneous forms that can make patients' life a little bit better. And, they don't have to be spending hours at the infusion center every month. They can give it to themselves at home. I think those are, big advancements as well in this field. I think that's pretty exciting. Like most of people, some of the reps that come in say they have moved off of the IVIG and now are getting the subcutaneous, which I think is exciting as well. And
Exactly. Yeah.
yeah, and that the immunosuppressant stuff that can be pretty hard to do as well. So how do you kind of support a patient who has to, be on those kind of medications in like their journey of getting treatment for their disease?
So if we do have to start an immune suppressant medication, as I said, it seems counterintuitive and like, wouldn't that lead to more infections? But it actually decreases the inflammation in the body and enables the immune system to kind of function optimally so that in the long run, they're going to get less infections. And we may also support them with using immune globulin therapy at the same time.
Okay, yeah, that makes sense. So you mentioned decreasing inflammation. So are there like lifestyle factors that they can do to support themselves on doing, decrease of inflammation overall as well?
Yes, I know that that's one of your areas of expertise is like wellness, exercise, supporting people on their wellness journey. So I am, interested in that. I'm a foodie, so I love to cook. I love to primarily vegetarian recipes, Mediterranean diet. So in that area, I'm not an expert in nutrition, but I certainly, can support patients with recipes or
Yeah.
or what have you if they're interested. I'm in discussions with various nutritionists in the area that I like to refer to. As far as exercise, there's a personal trainer that I refer to and an excellent physical therapist who does things like dry needling. I think it's really important to help people get in the best shape that they can possibly be in to
Mhm.
support their immune system, reduce the inflammation.
Yeah. Oh, funny you mentioned the dry needling because I had a doctor of physical therapy on a couple episodes ago about dry needling, and it was just enlightening for me of what they can do and how they can help people. So you'll have to tell me who your person is. But yeah, I feel like when we have talked previously that you were, wanting to help treat the whole patient, right? Even the name of your business, HealthSpan Immunology, you're kind of wanting to help them without their whole health, with their health span versus the lifespan. I think you really focus in on that. And I love that. And we can talk more about that in a minute. But I think, supporting these lifestyle factors while, they have to be on these treatments is very, very important. And I like that you
Absolutely.
have the people that can help you support you treat them better, like with physical therapy, dietitian, and, personal trainer, even. I think that's fantastic. Yeah.
Yeah, and it gives the patient a sense of control over their disease
Mhm.
because they've
Yeah.
spent so long being told that, nobody knows what's wrong with them, not getting the support that they need. And then, we can not only figure out what's going on, but also support them in those other ways and give them some control back. I also am very passionate about mental health. So I have kind of a cadre of mental health professionals locally that I refer to.
Yeah, I mean, that definitely has to play an important role too, like for, quality of life and what they've been through to probably just to get the diagnosis in the first place, right? You're definitely going to have some like trauma or micro trauma regarding that a mental health provider would really help out as well. Yeah.
Exactly. Yes.
Before I ask you another question, is there anything else about the immunodeficiency that you wanted to discuss?
Think so.
No, we kind of covered a lot of it, right? Yeah. Yeah.
Yeah.
I know it's complicated and really hard to explain, but I think you've definitely made it more easy to understand for the listeners. So I appreciate that. One of the other things that I know you're very passionate about is PANDAS, and I think that is along the same kind of thing here. But can you tell us what that is? What does the acronym stand for, and what does it mean?
So PANDAS is pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. Typically, we think about strep throat. as triggering this disorder. It was actually just in the past few months, like formally recognized by the American Academy of Pediatrics as a disease. There are a lot of people over the past 20 years since it was discovered that even doubt its existence, which mystifies me because if anyone has seen a case of it,
Yeah.
it's impossible to ignore. But PANDAS happens after a child traditionally gets a strep infection. And then shortly thereafter, they'll have overnight sudden behavioral change, whether
Mm.
that's increased aggression or OCD, which can manifest in a variety of ways. It's not just hand washing all the time or worried about contamination fears. It can manifest in other ways. Like, kids can have fears about their food being contaminated and not wanting to eat, or they can need to line things up in a very specific order, or maybe they need to touch things of a certain color. There's a variety of different fears that can arise that are actually OCD. They may also have developed a tic disorder. So they'll have abnormal vocalizations like sniffing or even just coughing or abnormal movements that are called tics. And if they stick around long enough, are called Tourette syndrome. So it can manifest in a number of ways, but PANDAS develops, we think, because strep infection triggers the development of autoantibodies that then attack part of the brain, the basal ganglia, leading to this variety of manifestations, the behavior, the OCD, the tics. And I'm interested in it from an immunology perspective, also because my younger child developed PANDAS. And I'm going to be starting a mentorship program in 2025 where I'll be interacting with experts in the field on a weekly basis, and I can present like really challenging cases to them for mentorship. But I'm really excited to be getting into this field. And I've already seen, several patients with this diagnosis. So
That's amazing. I mean, I have to admit, I have not seen any, but I don't see too many kids. So is it mostly in children? Can it be in adults? Is it always with strep, or is there another bug that can cause this?
So there's pretty good evidence that mycoplasma, which causes walking pneumonia, can trigger this disorder as well. There's a related disorder called pediatric acute neuropsychiatric syndrome, or PANS, which includes PANDAS, but can be triggered by any number of infections, viral infections. So really anything in theory could trigger it. And so I'm interested in seeing any kids that have that type of symptoms, whether or not they've had strep infections.
And so is there anything that can present in adulthood, or is this mostly in kids?
Yeah, that's a question that comes up a lot and I think needs more research. I think there are probably plenty of adults who had PANDAS in childhood, developed OCD in childhood, and just were never diagnosed and may persist with OCD or Tourette syndrome in adulthood. And going back and reconstructing that at this point can be difficult. But I certainly have some young adults who, have parents who are kind of on their radar and they've been, tracking over time. The kid had a history of what sounded like PANDAS in childhood and may benefit from antibiotic therapy even at this point.
Which leads to the next question. How do you treat it, right?
So we often start with ibuprofen or another NSAID at a little bit higher doses than what you would give just for a routine fever.
Yeah.
And then we do that twice daily, just as a trial, for like 5 days, 7 days. And then antibiotics, depending on which infection is thought to be triggering source after checking various antibodies and autoantibodies. We might try Augmentin if we think that it is triggered by a strep infection, or azithromycin if we're leaning towards mycoplasma. Just depends on what we think might be the trigger. And then the child may or may not need kind of a prolonged course of antibiotics. And
Mm.
then some kids actually need the IVIG or subcutaneous immune globulin, like we were talking about earlier. And I investigate their immune system before starting those products because I want to know how is their antibody function before replacing the antibodies.
So question for that. If the function is good, do you still try to treat with the immunoglobulin, or does insurance cover it if it's good? That's kind of my question there.
That's
Yeah.
a great question. Some people code for autoimmune encephalitis in order to get the immune globulins covered. And as an immunologist kind of entering this field, we'll see. I'm hoping, I
Yeah.
have relationships with some of the companies that offer these products, and they are great at working with me to get them approved. So I'm hoping that it'll be kind of easier for me. It's certainly easier for me to get immune globulins approved than it is for a hematologist or a practitioner, just in general. So I'm
Mhm.
hoping that it will be the case for Pandas kids as well.
Yeah, I hope so. I feel like there are a lot of conditions that we use immunoglobulin for, and I often forget that. I'm always thinking immunodeficiency, but even off-label use, like we've tried to use it for long COVID for a couple of patients, and very difficult getting anything like that approved. So I feel like I think you're on the right path, and hopefully that will work, especially for the way that you described the nature of everything happening. So I feel like it should be covered, but I guess more time will tell, right? I don't know the answer there.
And certainly doing the immune evaluation may uncover that some of these kids actually have an immune deficiency. Certainly that was the case for my son. He has specific antibody deficiency,
Okay.
and he's going to probably end up on immune globulin replacement.
Yeah.
So
Yeah. So what is, if like that didn't happen, what is the long-term management, or what are long-term effects if you don't treat it?
the effects are myriad,
Mm.
just the child suffering with severe mental health complications, the family. It's really hard on families. Siblings struggle because they get less attention. It can be really hard on marriages.
Yeah.
And then there are certain kids that do have underlying immune deficiencies and increased infections in general. So you want to get them on therapy to prevent not only infections, but exacerbations of pandas.
Mhm. So you can actually have an exacerbation even though you've been treated.
Yes, it can be a waxing and waning kind of presentation.
Okay. Wow. A lot, I think, to be researched in that field. Like you said, it's newer and it just got called you said a disease, right? Was it by FDA or who?
I
CDC?
believe it was the AAP that
Yeah. Okay.
finally
Sorry.
came out and
AAP.
said, okay,
Yeah.
we agree
Yeah.
this is a thing.
Yeah, yeah. I mean, some of these things are, just we're discovering, and it is, they're kind of crazy to think about how they occur, but like when, the research is done and everything, it's just very interesting and good that it's being brought to light so that these people can get better treatment and better
Yeah.
outcomes. So the other thing I wanted to ask you about, so we hear a lot about direct primary care, and here you are, like an allergist immunologist, and you're starting what I would say is a direct specialty care model. So what inspired you to do this kind of model, the direct specialty model?
So direct care means that the doctor aims to develop a very personalized relationship with the patient. They want to be able to spend as much time as possible with the patient. Many of my patients come with, 4 inches thick folder of records, and I want to have the time to go through those records and really address the many, many years often that patients have been searching for answers and really spend the time that they need. In order to do that, I have to use the direct model, which means that I don't take insurance for my consultation. I do bill insurance for medications, for lab work, for radiology, the other things, referrals that the patients need. But to give myself the time to really spend with the patients that I want, that makes me feel like I'm doing a good job in giving them what they need. I don't take insurance. Some of the patients, typically the direct primary care model is a subscription model where the patient will pay a certain fee monthly. I think the average is like $75 a month for direct primary care and $20 to $30 for each child, something like that, which is a great option for some families that either have high deductibles or don't have insurance or, just want greater access to their physician. Some of my patients would benefit from a subscription model, those that have more severe disease, those that really need a lot of coordination with other specialists. Got an immune deficiency. The immune deficiency has led to, them having a giant spleen, for which I have to refer them to a hematologist or what have you. They may have liver disease, and I have to refer them to a hepatologist. Doing all that coordination care requires an extraordinary amount of time outside the office, when the patient's not even before me. So I recommend that they join the subscription model. Some even will
So you have
require,
both.
I have both, yes. So they can come and be seen for just a consultation fee once or twice or whatever they need, or they can sign up for a few months of subscription services or whatever their preference is. But yes, I can do just a consult fee as well.
Yeah, I think in your field, like you said, they bring stacks and stack of records and to really understand what has happened before, what's going on with them. It'd be very helpful to have time to review them. And, in a 15-30 minute appointment in an insurance model, that's really not going to happen very easily. So I think, this really makes a lot of sense for immunology with these more advanced cases too. So I commend you for getting out there and creating your own practice. It's amazing. So, is there anything else you'd like to add for anything that we've discussed today?
So you mentioned the name HealthSpan, which I
Yep.
did choose because I like to follow people, through the lifespan and increase their health and wellness, which I think of as HealthSpan. My goal is to eventually get certified in like longevity medicine so that I
Mhm.
can offer longevity services because I think it's really exciting what we're learning about inflammation and how, certain patients are already using sirolimus, also known as rapamycin, because there's decent animal data saying that using that medication increases lifespan. Difficult to do those studies in humans, but I think the data is pretty exciting, and I'd like to be able to offer those services eventually.
Yeah, I'm glad you brought that up, like explaining why you named the business what you did. And I mean, I think that makes a lot of sense. It certainly goes along with your model there, the longevity practice. I think rapamycin does have some side effects, I think, from what I hear. Like it's more like an on again, off again kind of drug. But some people do have, I guess we don't even know if they're having success with it really, because like you said, you can't study it so well. But longevity medicine is pretty exciting. So I think that would be a great plus for your HealthSpan immunology practice. So I'm glad you
Yeah.
mentioned that. Anything else we forgot?
My ideal would be to be able to partner with someone to be able to prescribe rapamycin on a
Mhm.
research basis like, as part of an official research study.
That'd be cool. Yeah, very
So,
nice. So where can people find you if they want to work with you?
well, I have a website, www.healthspanimmunology.com, or they can email me at healthspanimmunology, all one word, at gmail.com, or call the clinic. It's 813-869-7111. And I'd love to hear from people.
And I think you have a Facebook page too, right?
Yes, I do. I have a Facebook
Okay.
page and I just started an Instagram page.
Okay. All right. So we will put all that information in the show notes and please, let me update me on the Instagram thing so we can add that as well. And I just want to thank you so much for coming on the podcast today. And this was an awesome discussion and I wish you best of luck in your practice. And I think you're going to do great.
Thank you so much, Dr. Reller. Thank you for the opportunity.
You're welcome.